talk about tips and tricks and practical application of intracoronary imaging, IVUS OCT, and FFR, IFR, and then Dr. Hamid will go with the evidence and data behind this technology. So we'll get started without any further delays. So what is IVUS? How it works? A catheter pulls back through a lesion or area of interest and results in a series of tomographic cross-sectional images of the vessel. Sound waves are reflected or pass through structures depending on their density or acoustic impedance. And 60 images are produced in a 1 millimeter segment using a pulse back speed of 0.55 millimeters per second. So there are two types of transducer available. There's a mechanical transducer, which rotates on a drive shaft at 1800 RPMs, which is the Boston Scientific technology. And this Volcano, now taken up by Philips, solid state IVUS technology, which is multiple 64 stationary transducers which emit ultrasound waves. Both have their nuances. That is the phased array catheter, which is the rotating catheter. Phased array is a fixed transducer catheter. It does not need any flushing before insertion. The rotation catheter needs flushing before insertion. You can have some blood speckle in the lumen with the rotation catheter, which is not seen with phased array catheters. And there is option of chroma flow, which is color Doppler for visual length flow, with the Volcano catheter, which is not available with rotation catheters. It is a little bit bulkier, the phased array catheter, so it might be harder to cross more severe lesions than the rotational catheter. And the resolution is generally 20 megahertz with these phased array catheters, but it can be much higher, 45 and 40 megahertz, but now up to 60 megahertz with the more recent catheters on the rotational catheters. For CTO crossing, phased array catheters are preferred because the imaging is closer to the tip. So this is an example of our, IVUS catheters in terms of the phased array catheters, which is Eagle Eye. This is what we have in a lab more recently, is this 20 megahertz catheter over here, which is a Volcano Philips technology. Rotational catheters are by Boston Scientific. They have more higher frequencies, so can get better resolution with that. And this is OCT, which we'll talk about later, is a dragonfly catheter, the images from that. So this is an example of the IVUS catheter over here, a diagram of those. This is the Volcano catheter that you can see over here. So the maximum diameter is 3.5 French at the transducer. So you can use a 5 French guide catheter or a 6 French guide catheter as well to use it. And it's like, advancing a monorail balloon system. And these have a little bit more complicated setup, but still quite easy to use the Boston Scientific catheters. This is the package insert of the Volcano catheter, same diagram over here. This is how it comes out when it comes out of the packet. It's literally plug and play. You just plug it into the transducer over here, and the console is on the side, and you're ready to image. And this is what the catheter looks like when it comes out. You advance it to the wire like a regular monorail balloon. And for an automated pullback, you just insert this back end, this over here, into this, and you can set the speed over here, and it will do an automated pullback. So very simple assembly and system with this system to use, and literally takes few minutes to just get it started and take the images. So what you're doing with the once you're going to advance the IVUS catheter over the wire, just like a monorail balloon, and what you're getting is cross-sectional images of the artery throughout. So perpendicular to the axis of the catheter. Now, I call angiography as luminography because if you're looking at a concentric lesion over here, yes, in different orthogonal views, they will appear the same. But for an eccentric plaque, it will appear with severe stenosis in one view, and in another view, it will appear mild. Similarly, with a complex disease, a lesion like this, it may just appear fine in all the views, but it may be much significant. So angiography has its limitations, and this IVUS complements angiography in many ways. And where it's utilized quite frequently and can be very helpful is imaging before PCI, especially in determining left main significance. If it's greater than 6 millimeters square, which I'll discuss a little bit later, or more, it can help defer that left main culprit lesion ACS, identifying the plaque and characteristics of that, angiographically ambiguous lesions, stent failure, determining the cause, whether it's stenosis and thrombosis, what was the cause of that, and determining the risk of embolization. And imaging during PCI, it can help with the need for lesion preparation. It can help with the CTO crossing, select stent landing zone, choose balloon stent diameter length and evaluate result after stenting, especially complex lesions like left main lesions, bifurcations, and calcific lesions. And also, IVUS can help reduce contrast volume as well by reducing the angiographic images we take, and we just can use IVUS runs post-stenting. So I'm going to go over the really basics for the fellow standpoint. That's what I've been doing in this talk. So, it's just one structure. We were looking at grayscale, so it can't be that complicated. And if you look at it again and again, you get used to it. So this is the media outlined. I'll go back again. This is the dark shadow is the media. Because it's smooth muscle cells, so their equilism appear as dark. And on histopathology, that's what it looks like over here. This is the adventitia with sheets of collagen that reflect a lot of ultrasound, that appears white over here. And plaque is dense and will appear different shades of white or gray over here, depending on the plaque respirators. And this is the lumen over here, and this is the IVUS catheter. And this is the lumen border. So this is what on ultrasound an artery will look like. Again, reinforcing that in both long axis and short axis view. So this is on an automated pullback that you have a long axis view on IVUS as well, and a short axis view you can get. This is the catheter highlighted in light blue. Then you have on green the media highlighted, and then you have the blood. Then you have the plaque highlighted in yellow over here, and then you have calcium on top highlighted, and the blood in the lumen here. So the basics of grayscale are that the less echogenic structures obviously appear black, which is the media, and the fatty tissues will appear dark. Whereas the more fibrous tissue calcification you have, it gets more white. So adventitia is fibrous and it appears more white or in the gray thing. And when you have calcification, it becomes more white. And in between, you'll have fibrofatty or fibrocalcific in terms of the palp appearance, as to how gray is that. So this is an artery with a minimal plaque here. This is the lumen catheter, and this is an artery with moderate plaque over here. So this is again the catheter, the lumen border. This is the intima with its plaque, and this is the tunica media, and this is the adventitia outside. This is again a vessel with the extent of coronary calcification. The IVUS can be very helpful. This is somebody with concentric calcification and more than 270 degrees calcification. Over here, you likely end up needing a rotablator to get proper expansion. This is a small arc of calcification where you could do without it. So it can help us determine the extent of calcification in the vessel as well. This is an example of somebody having a dissection post-stenting. Now, this is quite obvious, but a lot of times you're not sure after stenting whether to do stent or not, and IVUS can help you identify dissection flap, as you can see over here. And you can be certain before stenting what to do. This is an example of a patient who had stenting done. So it looks reasonably expanded over here, but really under-expanded in the proximal RCA. So post-stenting, IVUS can help in terms of how well the stent is expanded. And this is an example after where you have a tight lesion and you're trying to see what's going on. So there's a big intramural hematoma. Now, if you were to stent it, not distal, too much distal to the lesion, you are at risk of having this intramural hematoma travel downward. So understanding and knowing the pathology, if you stent distal to the intramural hematoma, you can spread it tracking down. And so IVUS is helpful in that regard in defining lesion morphology over here. And this is an example of just this artery over here. Again, catheter, lumen border. This is a plaque in the intima. This is sometimes you can see a nearby vessel as well as outlined over here. This is a picture of a mixed plaque where you have calcification. You have echogenic plaque over here. You have echolucent plaque area over here. And this is the acoustic shadowing behind the plaque that you can appreciate. This is a plaque with just a minimal plaque, almost normal artery, in minimal intimal thickening. This is the lumen border over here. This is the catheter. And this is the ruptured plaque site over here. You have a ruptured plaque and the loop created over here, crater created by that. And this is an example of a very well-opposed stent in the vessel wall. So this is the IVUS catheter, lumen, and this is the well-opposed stent over here. Now, intimal hyperplasia can be sometimes very low echogenicity and can be hard to see. The flushing in that regard can help. As you can see, intimal hyperplasia over here, and again over here. So this is the lumen, and this is the intimal hyperplasia inside the stent area over here. And behind the stent is the intima. And this is again the hyperplasia over here within the stent borders. So this is again example of a mixed plaque over here, and with 90-degree arc of deep calcium. And with the IVUS, the problem is if you're behind the calcium, you can't see because of a lot of times acoustic shadowing that happens. This is fibrous plaque over here, this calcified plaque, and this is the IVUS catheter. And then over here in the mixed deep and superficial calcified plaque, you can see because of calcification, sometimes you can get reverberations, which is like a image of the software image of the echogenic structure. And this is the deep calcium here and acoustic shadowing behind it. This is the fibrous plaque area. And this is the superficial calcium here. This is actually a rotational catheter, but you can see a guide wire artifact over here as well because of the guide wire being outside the system. Both the catheters use a monorail technology, but the wire is actually travels outside this as well in the rotational catheter. So this is an example of a fully opposed stent, and this is a malopposed stent. You can see a big gap behind the stent and between the lumen border, and this is the malopposed stent over here. There is some concept of axial or lateral resolution. By axial resolution, you mean you can look at the stent and see what's the strut thickening, as you see over here. And with a lateral resolution, look for stent strut separation, as you can see over here, which can be much better appreciated with the high frequency catheters. Thrombus can be sometimes difficult to appreciate. This is what it appears over here. And again, flushing, there's a lot of blood speckling over here as well. Flushing can help better differentiate that. This is a dramatic case of somebody with left main disease. Now, this was somebody shared it with me. This patient underwent cabbage twice, and third time in his, then he came third time for angio after the second time his grafts closed. He got an angio done. That's what it looked like. But when he got an IVUS done, there was no significant disease. And this is because sometimes you can have an oblong-shaped left main, which can appear severe in certain views, and it's okay in the other views. And so it's always before you commit somebody with left main disease to bypass surgery, I think it's very crucial that we are sure that the left main is significant. So the lumen area was just fine over here, 11.9 millimeters square. So more than 6 millimeters square, you can safely defer. Now this one is a left main where it appeared hazy distally. You can take all the orthogonal views. It's going to continue to look the same, and you can't be sure. So the proximal left main, large area, but in the distal left main, it appeared significant. Cross-sectional area of 3.6 millimeters square. So it appears quite significant over here. So, but again, I always use physiology if its area is less than 6 millimeters square. But this is significant left main likely. The area was 3.6 millimeters. You could not be sure on angio with this appearance. So a left main help you decide it. So this is a patient who came in with non-STEMI refractory pain and shock, was immediately taken to the cath lab. And this is what it looked like. Is circ was also occluded, but that was filling from the right, which was fine. The patient was stented in emergency situation. Now the patient is stable, chest pain-free, hemodynamics are better. What would you do? I mean, it looks good, but enemy of good is better. You would expand more. She may have problems, but when we did the IVUS, this is what the stent looks like in the left main, really underexpanded. This patient was have really problems if you don't do a right job for this patient and expand it further. So it was expanded further with a 4 balloon, and it got better. And geographically, it may not look dramatically better, but it got much better expanded after post-dilatation. Now, just a word about artifacts. Ring down artifact is seen by phased array catheters with this volcano IVUS catheter, and which is the you have a shadowing around the echogenicity around the IVUS catheter, and there is a ring down button that you can press to get rid of it. And NERD is the drag of the shaft of the catheter in the sheath of the rotational catheters, and especially in curvatures, tortuosity, you can see this sometimes with that. And blood speckle can be seen more with the high frequency transducer catheters, where the area of tight stenosis and sluggish flow, but you can flush that. As you can see, blood speckling over here, you can flush that to clear the lumen to better discriminate between the intima border plaque and the lumen if there's blood speckling seen. Also, there's a lot of motion, axial catheter motion. So the position of the catheter, you have to keep that in mind as well while you're imaging. Now, when you're pulling back, make sure you have the guide disengaged if you want to appreciate the osteal, aorto-osteal stenosis and RC or left main osteal stenosis. The reverberation artifact I showed before in one of the images is just an echogenic structure and can create false images. Same thing with side lobes. And position artifacts are that because of the vessel curvature, the IVUS catheter may be positioned close to the vessel wall. So just have to keep that in mind as well during imaging. Now, with the virtual histology is the thing which is available with the volcano technology. Basically, the ultrasound signals are the radio frequency signals that go back have a tissue characterization based on the signals, and then they're color coded. And based on that, picture and on that algorithm, a picture is created like this, and which has been correlated with some histopathologic studies as well. So you, based on the frequencies you get, you color code and assign them fibrotic, lipidic, necrotic, or calcified. And reasonable studies to show the histopathology correlation. This is only for research purposes, no real practical use, and I don't use it routinely, but a good thing for research purposes. This is a feature which is only available with the volcano technology, that you, like Doppler in echo, that you can the blood appears red, and in this case you can see a dissection flap, and over here you can see a malopose stent where you can see the blood behind the stent. So now this is a new thing which is out there with Philips. When I was working in US in December, this co-registration system which is available, that you do a pullback of the catheter, and along with that you also do fluoroscopy run, and you've taken an image with the catheter in, and you can see on angiography exactly what point what IVUS images appears. So it becomes much easier, and as I'll show later, iFR can be done along with that as well. So it is really cool that you have the iFR image of the whole vessel run on the screen, and along with the IVUS images and the angiography all correlated together. So this co-registration feature is available with the Philips technology. I don't know if the others are providing, but this is a nice feature to have. So what measurements on the stents can be done? You can look at lesion significance. The basic measurements is person lumen area, minute lumen area, again, and interventional sizing measurements, diameter, length you can measure. And for research purposes, you can look at plaque burden. There have been trials with statins have you seen to follow up if the plaque burden went down or not, and so forth. The multiple trials using plaque burden for research purposes, and post-stent measurements, whether the stent is properly expanded or not. What about the area, indeterminate left main? For that, there have been multiple studies out there. There was a trial of deferring for 7.5 millimeters square. Then there was a trial with 6 millimeters square deferral where patients did fine. But for Asians, there have been trials for 4.5 millimeters square deferral as well, and 4.8 millimeters square deferral as well, on which Dr. Hamid will discuss more in detail. So I personally use 6 millimeters square cutoff. If left main is more than that, then in that case I feel comfortable. Less than that, I'll go for physiologic studies. What about other vessels other than the left main? There's so many trials with so many diameters. Generally, more than 4 millimeters square, it's likely not going to be physiologically significant, but I use FFR technology for that purpose. So because everybody is burned with a different coronary size. So this all, initially, a lot of people stented unnecessarily using these criteria of less than 4 millimeters square on the IVUS. But for vessels other than left main, greater than 6 millimeters square area, I personally don't go for areas in other than left main for defining significance, whether to intervene or not. So this longitudinal view can really help you in terms of the vessel stent length to be used in the vessel and the diameter to be used. So this is the proximal reference area. This is the difference reference area where you use B1, B2, and which you measure the length, and then you can measure the diameter as well with the proximal reference, distal reference, and for the stent, and then and the length, and this can really help you. So automated pullback. A lot of times you're doing manual pullback, but use automated pullback can help you get a good length estimate of the stent as well. So what are you looking for in stent expansion measurements? Ensure opposition to the vessel wall. Measure stent lumen area at the tightest point. Compare measurement to distal reference lumen area. And stent MLD that is 90% of the distance reference lumen area is generally considered fully expanded as is what you want. Now, certain things that you want to look for after the stenting is whether the stent is fully expanded or not. If any malposition, that is exit distance less than 0.4 millimeter or less than 1 millimeter length, or if any dissection flap noted, which is greater than 60 degrees or greater than 2 millimeters length, you would worry about it. You don't want to see any dissection at all. And any tissue protrusion, these are all signs which are worrisome. If you see any of these, that can lead to stent thrombosis. But minimal stent area is the key. That if greater than 5.5 millimeters square it correlates with very good long-term outcomes. You also watch out for intramural hematoma, and you also watch out in the distal and proximal reference area. There is no significant stenosis greater than 50% at the stent edge. So this is a picture from actually the editorial just published in the JACC. And I think this was in the ultimate trial, the criteria used, that the minimum stent area should be greater than 5.5 millimeters square or 90% of the different distal reference lumen area. And when you're landing the stent, there should be no edge dissection and the plaque burden should be less than 50%. So this is the criteria used in the ultimate trial. And I think there is no uniform consensus, but this is a pretty good criteria to use, which I also use in practice in terms of appropriate stent deployment. And you want it to be fully malopposed as well in most cases. But regarding malopposition award, these are all the, a busy slide. Malopposition, as we initially thought, would lead to stent thrombosis. And I think it still does, but it wasn't thought to be as bad in all these trials in terms of MACE follow-up if you had a little bit of malopposition as noted in these trials. And things that mattered most was, whether was distal and proximal reference vessel narrowing or not, if there's a distal edge dissection, and also if there is, what is the lumen area at the end. So if you have lumen area less than 4.5 millimeters square, or there's greater than 50% narrowing at the distal and proximal edge, or there's an edge dissection, those things are statistically significant in terms of MACE rate of death, MI, stent thrombosis, and TLR. Now switching to OCT, relies on backtrack scattering of light by reflection and to obtain cross-sectional images of tissue. It has a 10-fold higher image resolution than intravascular ultrasound. Now the Fourier domain OCT technology is used. Initially it was thought that we don't have any data with OCT, so it's just now we have enough data in terms of non-inferiority trials comparing with IVUS. The guidelines have also endorsed it with the Illumian and Opinion trial, and the doctor's trial also supporting that it can be used as an alternative technology to IVUS, and it will do the same thing, complementing angiography like IVUS. So comparison with IVUS, it's near infrared technology. Wavelength is around 1.3 millimeters was 35 to 80 millimeters over here. Resolution is 15 micrometers. It's 100 micrometers over here. And maximum penetration is 2 millimeters on each side of the catheter. It's 10 millimeters over here. And you can image through calcium with OCT, which you can't through IVUS because of the acoustic shadowing that happens. This is what the OCT catheter looks like. Similar to the system that is with IVUS, unless you have integrated in the lab. And this is where you plug in the catheter, and this is the light source area and where you get the images as well. This is what the catheter looks like. It's very simple, again, plug and play. And when you have to inject contrast or dextran to take the images because you want to clear blood through the artery when you're taking the OCT image. And actually the sheath of this catheter remains in place when you're taking the image. It's the this transducer which moves back to measure that length of the, to image that length of the artery when you press the button for imaging. But you have to time the contrast well and clear the blood well for good images. So this is what the images look like with OCT, much nicer, prettier pictures. This is a picture of plaque rupture. This is a picture of red thrombus over here. This is what the white thrombus looks like, and this is what plaque erosion looks like. Now, this is with the Clio registry, some of the criteria looking for in OCT on stenting. So stent malposition greater than 500 micrometers. This is somebody with edge dissection greater than 200 micrometers. This is with thrombus thickness greater than 500 micrometers. In-stent MLA less than 4.5 millimeters square is correlated again with adverse outcomes and increased MACE. And this is somebody with significant residual stenosis at the edge of the stent. So, this gives a good idea of how well OCT can be in terms of morphology of the plaque. This was somebody who had a cutting balloon done, and on angio it looks really smooth and nice. On IVUS, you can't really appreciate well what happened with the balloon, but over here you can see all the fissures created by the cutting balloon on OCT. So much better resolution pictures and nicer pictures over here. Again, with stenting, this was a patient who stent done 7 months ago. You can't really tell if there's any intimal growth on the stent, but on the OCT, you can see this intimal growth on the stent very nicely. So there's a catheter lumen border, and this is the growth on the stent. And in terms of calcium, the IVUS, you get this acoustic shadowing, but with OCT, you can see all the way back over here, the depth of the calcium as well. So some of the advantages, disadvantages of OCT over IVUS, for left main lesions, IVUS is better. For ostial RC lesion, also IVUS would be better. And for ACS, thrombus, for that OCT can image better. For contrast utilization, IVUS is better. CTO crosslink, IVUS is better. But in all the circumstances, you could use either IVUS or OCT. Image resolution obviously is better with OCT, and you don't need any contrast imaging with the IVUS. And I think these are the same things which mentioned in the previous slide. So guidelines, for intermediate stenosis of the left main artery, IVUS can help define lesion severity. For all the other vessel structures, no role. You can defer based on IVUS, but not intervene based on IVUS. Unless you have physiologic information or clinical symptoms correlating with that. Recommendations for use of IVUS imaging. Otherwise, in patients undergoing coronary stent intervention, IVUS can be useful for procedural guidance, but in cases of left main complex coronary stenting to reduce ischemic events. And OCT has been considered as a reasonable alternative with the recent trials. In patients with stent failure, IVUS OCT is reasonable to determine mechanism of stent failure as well. So these are the guidelines when 2A indication to all IVUS and OCT. This is from the 2021 revascularization guidelines. Now I'm switching gears to FFR in the last 5 minutes or so. Grenzik, the FFR technology, this physiology for coronary vessels have been studied since 1979. And they were measuring pressures across the lesion. Problem is they did not have a 0.014 wire. They were making the balloon cross and measuring pressures through that. And there's a gradient with the balloon catheter itself that is created. Eventually, they got a 0.104 wire and finally a transducer at the end of it. And we were able to measure pressure gradients across the lesions. So what is FFR? FFR is not resting flow. It is fractional flow reserve. It is maximal achievable flow, which determines the functional capacity, exercise tolerance of a patient at maximal vasodilation corresponding with maximum hyperemia or with maximum exercise. So it is and blood through the myocardium is proportional to the myocardial perfusion pressure. So hyperemic distal coronary pressure is what you're getting with FFR. And it's basically the ratio, in simple terms, mean aortic pressure at maximal hyperemia, which is below, and mean distal coronary pressure at maximum hyperemia. I'm not going to go back into too much into physiology over there, but this is the basic equation that you need to remember for practical application. So you have the catheter, you cross with the wire is a transducer over here, so you measure pressure here, which is a PA, and PD over here, and you get with maximum hyperemia, you measure the ratio, and if it's less than 0.8, it's significant. Now, iFR has really made the usage of this technology much helpful in the instantaneous wave-free phase in the diastole over here, where you can measure an iFR, and with that ratio, you don't need any hyperemia to be given. So this iFR has been well validated as well. So these are the indices which have been used: hyperemic indices FFR, and non-hyperemic indices, PDPA. Not much for all the other, not much data to support use. Only the iFR and FFR. But if you cross with a wire and it's less than 0.91 without any hyperemia, most of the lesions are going to be turned out to be significant. But you need to confirm it with either hyperemia with FFR and or IFR less than 0.89. If it's less than 0.89, then it's significant. So what are the steps you need to watch out for? This is some of the FFR wire. That once you take the wire out, you need to flush. Then you need to calibrate or press the 0. Most of the time with the volcano wire, when you connect, it's an automated 0 system. Insert the pressure wire to the tip of the guide, and then remove the introducer. That's very important to remove the introducer for the wire, and flush the guide catheter with normal saline, and then push the equalize button to equalize the pressures. And then you advance the pressure wire distal to the target lesion, and then you measure the resting physiologic indices. And then you give hyperemia. Now, for hyperemia, you can use IV adenosine is the which was used in the most trials, and sometimes intracoronary adenosine also reasonable data to support its use. And then you do a pullback, make sure that there's no drift when you come back into the guide and the pressures were equal. So that is the steps you follow. So what are the pitfalls that can happen if you don't calibrate properly? If the wire is not equalized at the right point. And regarding measurements, they can be drifting, wedging, whipping, hyperemia to watch out for, and cursor position. I'll go with these with examples. For hyperemia, I would say 140 micrograms a minute, the same dose that you would use for IV adenosine during stress testing is what is recommended. After 2 minutes, you start seeing the hyperemic response, and then you start doing the measurements. For intracoronary, you can use up to 50 to 100 micrograms for the left coronary artery system and 30 to 50 micrograms for the RCA. If they tolerate that dose, okay, then you can give an additional dose as well. And when you have the cursor on the FFR tracing, make sure that some machines have the options that you can run it across. Make sure the cursor is at the position where the tracing was appropriate and there was no artifact. So this is what the FFR wire looks like when it comes to the pocket. Key thing is that once you have the coil, this wire packet down and you flush it, leave it there for good 60 seconds before you hook up the wire with a transducer, and you press the 0 button, because otherwise you may not calibrate properly. And the wire is like any other 0.14 wire, is just not as talkable. And then after you've done the FFR measurements, you can actually disconnect it with the system and do a plasty over that wire. And this wire can be used multiple times through for multi-vessel PCI, and post PCI also you can do measurements by reconnecting over here. So fill the tube of the wire with saline before zeroing. Wait for 30 to 60 seconds to have the wire completely and stably wet before performing calibrations. That helps with proper zeroing. And when you are at the guide wire tip, make sure when you press the equalize button that these tracings are superimposed on each other, you're equalized properly. Now, what is drift and what is the true gradient over here? So, you can look at the tracing for the sake of time. I guess we don't have question answer thing. So this over here, you can see ventricalization of the distal tracing. So this is a true gradient. And these pressures looking really identical, parallel to each other, but down there's an example of a drift. So this is and when you pull back over here, the FFR was actually significant, but when you pull back, you notice there was a drift at the tip of the catheter. And when you equalize again and pull back, actually the FFR was not significant. The gradient was higher across the lesion because there was a drift accounted into it as well. So why the drift can happen? These are all the mechanisms. These are technical reasons that, if the aortic, when there's a busy slide, variability of the aortic pressure transducer high, post measurement, inappropriate pressure wire calibration, debris on the pressure wire connector, not removing the needle introducer, using guide catheter with side holes, contrast medium with the catheter. So always flush the catheter during measurement, take the introducer out, and make sure during measurement, you don't have any debris on the pressure wire connector when you're reconnecting, especially. And excessive intubation of the guide catheter can also make false measurements. And then there are technical issues when the system itself, with the temporal pressure, mediate pressure wide signal drift, or temperature mediated signal drift can happen, but with the newer wires, this is not normally seen. So key thing is, after a measurement, pull the wire back into the transducer, into the guide catheter, make sure the pressure is still equalized and you got the right measurement. So verification of equal pressures in back and guiding is very important. Now this is somebody, you can see that the guiding catheter was engaged too deep. So you can see the aortic pressure is also ventricularized. So that's how you can tell that the guiding catheter is also ventricularized. And over here, the actually FFR was not significant, but when you disengaged, the gradient was bigger because the aortic pressure was higher. So this is the tracing where where the guide catheter was disengaged, and you could see. And this is an example of the whipping. That if the wire is not moving a lot, then you can just get whipping. So you don't want it to be wicking when you're making a measurement there, because it can get false reading there. And now just an example of the coronary over here. This is ostial circ, which you could not see in any views as to how tight it is. When you did an FFR, you saw it was significant. This is an example of multi-vessel coronary artery disease. You could see 70% RCA lesion and tight circ. LAD is borderline, you're not sure. You do an FFR, and this is what it shows. The LAD is not significant. And then the left circumflex turned out to be significant, 0.55, and the RC is also significant. And you could do FFR after the RC as well, where it was greater than 0.9 is good outcomes data supported with it. So it was 0.95 over here. Again, co-registration option is available with FFR, so that is a very neat option that you can look at. So with iFR, the technology that I think the usage has gone up. There was a lot of hesitancy using the intravenous adenosine, and you had pauses, and then with the pauses, sometimes there is a risk of even DTBF and converting into AFib and asthma and all that. Intracoronary adenosine was safer, but with the iFR technology, now the usage has really gone up. And with this, again, co-registration system that you do a wire pullback with fluoroscopy, and you can see exactly where, especially with diffuse disease, as to where the IFR gets better, and where would be the best area to stent to decrease the gradient and improve vessel physiology. So I think aorta lesions, you need to disengage the guide. This is some of the caveats you need to keep in mind. Left main, assess both LAD and left circumflex plus pullback. Now, CTO donor vessel FFR. If you were to fix the CTO, the donor vessel FFR will go up by 0.03. The donor vessel lesion FFR will go to 0.03 to 0.1. So it was 0.79, it will go up to 0.82 or 0.89. So FFR is not dependent on the degree of stenosis, but the area it supplies and the viable myocardium it supplies. So that is a key point to remember. And if you have discrepancy between resting and hyperemic indices, then you have to use clinical judgment. It's not been well studied in SVGs, not studied in ACS culprit lesions, but non-culprit lesions, you have enough data now. And also in decompensated heart failure, physiology is not reliable with FFR. Again, endorsed by guidelines, but if you have FFR greater than 0.8 and IFR greater than 0.89, you can safely defer. And if don't do it if you don't believe it. I've seen people with 0.8 to 0.83 FFR and still go ahead and stent it. You did it for a reason and believe the technology. Now I'll end with this last slide. There is the value of experience is not in seeing much, but in seeing wisely. There's a quote from William Osler, and I think we'll now transfer to Dr. Hamid for sharing his data. We started 10 minutes late, so I think we'll go up to 10:10 in terms of the session. Dr. Hamid.
Okay, thank you very much. So I'm going to share my slides now. So I hope all of you can see my slides.
Yes, sir, we can see your slide.
Okay, thank you. So first of all, I'm very thankful to the PCIC for giving me the opportunity to talk on a very interesting, a very important topic when it comes to data. As we all know that we have been frequently using fractional flow reserve, IVUS and OCT, and at times we at times think that what's the data behind it, how robust is the data, are we short using it wisely, and if you're deferring a lesion with an FFR of more than 0.8, and if it looks clinically significant, looks angiographically significant, are we safe to defer such patients? So it's very important for us to know the data behind this and be sure that we are doing the things appropriately. So this is the outline of my today's presentation. First of all, I would let you know about the introduction, what physiology and anatomy really is. Then I will talk about the FFR, the clinical trials and the outcome data, the intracoronary imaging, the IVUS and OCT, the evidence behind IVUS, the evidence behind optical coherence tomography, which is a kind of a new emerging technology, still a lot of work being done, and what the take-home message from today's presentation would be. So this is what the outline would like. We start from the introduction. As you all know, that the disease process in our body is always an interplay mostly between physiology and anatomy. And when it comes to coronary anatomy, any disease that is coronary artery stenosis, whether it's being caused by a stable plug or unruptured or ruptured plug, it's always an interplay between the physiology, the flow that the particular lesion causes, and the plaque morphology that is the consequence of that problem. So anatomy and physiology go hand in hand. FFR will give us the degree of severity of that stenosis leading to flow disturbances, as Professor Nauman has clearly outlined the importance of FFR and how you measure it. So if there is definitely a lag in flow because of that particular region, it will definitely give us a number less than 0.8, and it gives us the idea that we need to stent it. Anatomy is important in mostly in acute coronary syndrome cases in which you may need to know what the plaque morphology really is. And it's very important in terms of your procedure management, whether you want to take which size of stents, how do you want to deploy it, normal to normal, post-deployment, and all these issues are sorted out by anatomy, most specifically IVUS, and in recent studies, OCT is coming up as well. So when we come to the flexion flow reserve, there's 5 important questions that do come in our mind when we are trying to stent a vessel or not to stent or defer a stenting for that purpose. Is first of all, is it safe to defer PCI if FFR is negative? So that's a very important question. The first important, is it safe deferral or not? For example, if a lesion looks angiographically critical, and if you do an FFR in the setting of specifically stable ischemic heart disease, and it comes to be more than 0.8, is it safe to defer such PCI? We are at times very apprehensive that whether it looks tight, it might give the patient a particular kind of an event, but whether it is safe. So this is the first question that need to be answered, and we need data for that. Is FFR really superior to coronary angiogram when it comes to borderline lesion? So at times we do an angiogram in stable heart disease patients and we get a lesion. And do we really think that FFR guided PCI is superior to angiography guided? is it indicated to stent a vessel if FR is positive? At times we see patients in whom ischemic testing is not done. He falls into on our table. We do an FFR for that lean because we think the patient is not that symptomatic. FFR comes to be significant. Now, should we stent such leans? Because nowadays, as you know, undue stenting is not good as well because it has its own share of complications. So this question, whether it is always, almost always indicated to stent when FFR is positive, that has to be delineated through studies and trials as well. And if FFR is that good, then is FFR guided PCI in multivascular disease non-inferior to CABG? Can we take FFR if it has got a robust data based on the preceding questions, the answers of the preceding questions? It is that robust and that good tool that it can compete, or that it can, at terms of non-inferiority with CABG in terms of multivascular disease. And very important question. At times we see FFR in ACS patient. This is as robust or as good as in stable. So all these questions need to be answered. So first of all, historically, I will go with the DEFR trial. It was the first significant trial that came into the system when it came to comparisons of FFR. So it tested the safety of deferring PCI of non-ischemic patients confirmed by FFR 0.75. So this is what really is the first question that was under consideration. So it is the only RCT on FFR with 15 year outcome data available. So this is kind of a very hardcore outcome data that we have 15 years of outcome available. So the endpoint in this case for combined MACE, which this picture represents, is death because of cardiac ailments. Number 2 is MI, which is non-fatal, and number 3 is TVR, or the target vascularization. The secondary endpoint was combined MACE at 5 years, and individual components of the MACE, which is death, MI, and revascularization at 2 and 5 years. So this is what this data studied. If you look at the randomization, this patient included those who had more than 50%. So first point that has to be delineated over here is that all those patients who were included in the data, they were deemed to be stented based on angiographic evaluation. So all these patients were then randomized into 2 groups. Now this is, since it is based on the deferral, so I would like to study the 2 subsets, which is the defer group and the perform group. So those patients in whom FFR was more than 0.75, they were deferred, and another group in which the FFR was 0.75, they were stented. So these are the 2 main groups. In addition to that, we had a reference group as well. So it included those patients in which the FFR in either group was less than 0.75, and they were studied, stented as per the guidelines. But the main purpose was comparing the 2 groups, that is those patients who were deemed necessary to undergo angioplasty based on angiographic findings. They were then subdivided into 2 groups, and those patients whom FFR was more than 0.75, that was considered not significant, and they then stented half of them, and another half of them was deferred. So this is the 5-year follow-up. If we compare the first 2, which was the defer and the perform group, you know that although the results are not that significant, but you see the event rate was much more in the perform group as compared to the defer. So in 3.3 versus 7.9% of those patients who enter one PCI had the event in the form of ischemia-driven revascularization, MI, or death. Now we come to the right side of the slide. It again shows that those patients, there was hardly any difference when it comes to clinical symptoms in 1 year, 2 year, and 5 year outcome in those based in the defer and in the perform group. So this shows. So this is the 15-year follow-up. And at the 15 years, if you see the large side of the slide, all the myocardial infarction was not different. In the defer group, it was 30, and the perform was 28. And if you look on the right side, the mortality, again, it was not different. A very important aspect of this 15-year follow-up was the MI in the defer and the perform group. And you also know that it was very, very less compared to the perform group, in which the target vascular revascularization, or MI, was seen considerably higher in those patients in which the performance of PCI was done. So this shows that those patients in whom the FFR is more than 0.75, it is very, very safe to defer such patients rather than stenting them. So this is what we got from this trial, that there's no differences in mortality. They have significant advantage in favor of defer group in terms of myocardial infarction, and there was no difference in terms of PCI and revascularization. So this answer is our first question. Is it safe to defer PCI if FFR is negative? Yes, we definitely, based on this trial, 15 years of robust outcome data, which shows that yes, it is definitely safe and sound to defer a patient in which we have an FFR of more 0.75%. Again, I must stress, at this moment in time, we are talking about those patients who present us with stable ischemic heart disease in most of the cases. Now we come to the FAME trials. This is the Hallmark Trials of Ffr. The FAME 1, the FAME 2, and the FAME 3 now is also available. So these are the three subgroups of trials which give us quite a value data when it comes to. It must be said that all these trials were randomized controlled trial, and they shaped the guidelines considerably when it comes to the pressure wire assessment of intermediate lesions. So the first was Ffr compared to angiography for guiding percutaneous coronary intervention. So again, I must say that in these patients, lesions with more than 2 identified vessels were considered for PCI. Again, these were those lesions in which it was defined that they, based on angiography, required intervention by a group of cardiologists. So they were divided into 2 groups. 509 patients were angio-guided, that they underwent angiography as angiographic guided angioplasty as they would normally do in our settings that we normally do in most of the cases. If the lesion is found to be significant, regardless of the FFR being done, it was not done in that group, and it was tended based on the clinician's preferences, considering the degree of stenosis. And another group that we had, all those patients who were deemed considered to be PCI were then underwent FFR, and they underwent FFR guided intervention. That is, if the FFR was less than 0.8, if the patients were proceeded with angioplasty, and those patients with FFR was more than 0.8, they were considered medical therapy. The primary endpoint is again MACE, which was death, MI, and repeat revascularization. So this is the interesting results that we came up with in the FAME trial. In 1-year outcomes, as you see, the rates of death, MI, and repeat revascularization was considerably less in the FFR guided arm compared to the angiographic guided arm. And the two things that were significant were a combination of death, MI, and an overall MACE. So you can easily see that those patients in which FFR guided stenting was done, it was considerably better compared to angiographic guided PCI. And as you can see on the right side, again, the 2-year outcomes also showed that the curves were kept apart even at 2 years and at the same rate. I mean, the degree of differences in that primary outcomes were to remain constant over a period of 2 years' time. So based on this data, it showed that the rate of death and MI and MACE was considerably less when FFR guided PCI was done in those patients who had clinical stable coronary stenosis deemed necessary to be intervened. And then they were divided into 2 groups: PCI guided, angiography guided PCI, or FFR guided PCI. And as we saw, that FFR guided PCI was still considerably better. So this is another important aspect. A lot of people talk about the finances that FFR will cost lots, but over a period of time, if we routinely do FFR in intermediate kind of cases in which we think that we may get away with stenting, it showed that the number of stents in the FFR group were considerably less. There was 2.7 versus 1.9. And again, the expenses overall in the study was much less in the FFR guided arm, because we used less stents and less balloons, and all those things were much less used in the FFR arm considered to the angiographic arm. So this is a 5-year outcomes again. The 2 curves are still very much further apart from each other. And so 5-year outcomes trials are available with us. And this again shows that FFR guided PCI compared to angiographic guided PCI is much better. So this answers the second question, that is if really superior to angiographic guided based on hardcore endpoints, which is the MACE 5-year MACE. So we come to the FAME 2, another important study. So the clinicians then, or the trialists then considered, well, if FFR guided PCI is being done, then what about the medical therapy? So what they did is that in all those patients in which FFR, coronary intervention would be deemed necessary, they randomized them into 2 arms. In those patients in which the FFR was less than 0.8, they were then divided further into 2 arms, but PCI plus medical therapy and the medical therapy. Now, this answers a very important and interesting question, that those patients in which FFR comes out to be less than 0.8, and if they are asymptomatic or minimal symptomatic for that purpose, should we routinely stent them? Now, on one side, the patient doesn't have any significant symptoms, and on the other side, the FFR is less than 0.8. So is it safe for such patients to be stented, or is it safe for such patients to be carried on medical therapy? So this is the theme of this trial, FAME 2, a very interesting and important trial which answers this question, whether we should stent significant lesions based on FFR, whether the patient, regardless of the fact the patient is symptomatic or not. So these are the primary endpoint. Again, The red curve showed that those patients who were undergoing medical therapy, they didn't do well, and they had increased incidence of MACE over a period of 12 months. In compared to that, those patients on whom the PCI was done, those patient FFR less than 0.8, with regardless of the degree of symptoms, those patient underwent PCI, the MACE was much less. And you can see that it was quite close to the one in which the FFR was more than 0.8, and they were kept on medical therapy based on the pre-existing guidelines. So not much difference in those patients. So this showed that this patient, that FFR guided PCI, regardless of the symptoms, if the patient has minimal symptoms, we can consider if the FFR comes out to be significant, we can easily stent them regardless of the symptoms, and even if their symptoms are minimal, because the hardcore endpoints that MI and urgent revascularization over a period of 1 year do well. And these results also held well at 2 years. You can see that even in 2 years, the curves are still very well wide apart. But important thing that those who argued about this trial, when the subsequent subsets of the endpoints were studied, they showed that this difference in the MACE was significantly driven by urgent revascularization. So they said, well, such patients may need revascularization in subsequent days or subsequent period of time. That why, if they don't differ the medical therapy in PCI in terms of death and MI, then they may not need to do urgent revascularization. However, when the urgent revascularization was further studied in detail, they found that most of those patients who were undergoing urgent revascularization were either having MI, unstable angina only, and unstable angina plus evidence of ischemia on ECG. So a considerable chunk of population, that is 40% of those patients are having acute coronary syndromes, which also, as you all know, carries a high degree of morbidity and mortality. So this shows that those patients, even who were going urgent revascularization, were considerable high risk of having a mortality or morbidity for that purpose. So that is why the FIM2 trial showed that those patients on whom FFR guided PCI is done, even despite having minimal symptoms, they do well compared to those patients who are kept on medical therapy alone. A very interesting trial came up recently, the FAME3 trial, which compared FFR guided PCI as compared with coronary bypass graft surgery. So it's a very interesting trial in a way that it compares FFR guided PCI. Now we all know that FFR is the gold standard, and if we do an FFR guided complete revascularization of 3 vessel disease or 2 vessel disease for that matter, is it as good as CABG? These were the results. However, the PCI didn't do well compared to CABG. It was considered inferior or not non-inferior to PCI in that purpose. And you can see, however, the initial trial showed that the subgroup analysis showed that those patients in which the syntax was 0 to 22, the PCI, the FFR guided PCI group did well. So this showed that those patients who have a low syntax score 0 to 22, those patients do considerably well in terms of FFR guided PCI compared to CABG. This is what our normal practice routinely is as well. So those patients who have flow limiting lesions and those who have angiographic or anatomical good scores based on syntax, we tend to send them and they do well. So the findings did not support which, however, if you can see on the left side, the safety endpoints, they showed that those patients in PCI, the bleeding, the arrhythmias, the kidney injury, the rehospitalization within 30 days, the PCI did well. So we should not discount PCI, multi-vessel PCI straight away based on this one trial. We can shoot the whole things in picture, the short-term outcomes, the long-term outcomes. Yes, FFR-based PCI is non-inferior to CABG when it comes to intermediate to high syntax scores. However, in low syntax score, FFR is as good, if not better, to CABG when it comes to intervention. FFR in ACS, it is hot topic nowadays whether we should, because the guidelines have somewhat changed based on the recent trials. Initial trials showed dynamic and compared that complete revascularization in addition to probability did well. In NSTEMI, they did FFR, the famous and the defined play trials in both FFR guided PCI was done, and it did show initially that FFR guided PCI results better even in the culprit as well as the non-culprit lesions. However, this recent trial, the FLARA might have shown so it showed recently that FFR guided PCI in both the culprit and non-culprit, in the non-culprit lesion in terms of STEMI don't do well. So still a lot of work need to be done. IFR with FFR, so yes, sir.
Sorry, you've, the 20 minutes are up. So if you could just wind it up in the last few minutes and show just the summary slide so that we have time, 5-10 minutes for discussion.
Okay. So iFR versus FFR, so definitely it did well. So although I didn't have enough time because there was trials on IVUS and OCT as well. So
we can go show the summary slides of the IVUS trials, switch to that.
So that was nice. Okay. So if you go to the IVUS, these are the different trials which were done. If I would go into this slide, which is very important. So this is the two important trials which were done, IVUS XP and the ultimate combined trial. And it showed IVUS-based PCI in intermediate and long lesions, complex lesions, both IVUS and ultimate, both showed better outcomes in terms of MACE when IVUS was compared to angiography alone, guided PCI alone. And this is the meta-analysis of all the trials that have shown that IVUS guided PCI showed better compared to angiography guided PCI. If you look at the optical coherence tomography, we have it is a trial which is in nascent phases, and it is an emerging technology. And we just stress upon the Illuminion 3, which showed that protocol-guided stent placement and stent-guided do well in those patients when it comes to hardcore outcomes. We have compared to IVUS, OCT was non-inferior when it comes to stent sizing, and when it comes to study analysis showed that IVUS OCT compared to IVUS picks up much better in terms of stent dissection, malapposition, and stent apposition. So OCT guided PCI using a specific EL-based stent optimization study was non-inferior to IVUS guided PCI for achieving MSA. OCT guided PCI resulted in superior stent expansion and procedural success compared to angiographic guided IC. OCT guided PCI resulted in the fewest untreated major dissections and areas of major stent apposition. So this is the new trial that is still in process, and it compares OCT guided PCI versus angio-guided PCI using a definite trial, and it is going to compare the hardcore outcomes, whether OCT guided PCI do well in compared to angio-guided PCI in terms of cardiac death, target vessel MI, or ischemic driven TVR. At this moment in time, we have all trials which have compared OCT with either IVUS, and their OCT has been shown to be non-inferior to IVUS when it comes to stent apposition, malapposition, stent deployment, etc. However, whether it translates into the hardcore outcomes like the FFR was in terms of TVR, MI, or death, it is still to be shown. So this is the guidelines that the Professor Naseer has always shown. If you look at the summary, we must think that FFR versus IVUS OCT is always physiology versus anatomy, and both of them have their own benefit. They augment each other. They are basically IVUS and FFR are two different entities. FFR shows the clinical significance of lesion, and whether we can stent a lesion based on those results or defer a lesion based on those results. It is totally physiology. It shows us the flow and doesn't give much of an idea about the plaque. When it comes to IVUS and OCT, at this moment in time, it gives us two important indications: the plaque morphology, the calcium, whether we need to do certain rotablation in terms of highly calcific lesions. It gives us a lot of idea about that. And when it comes to stent apposition, stent deployment, it gives us a wealth of information, which in turn translates into clinical outcomes as well. That those patients in which IVUS or OCT guided stent deployment is done, they do well compared to angiographic IVUS. Assist in decision making. Future of coronary intervention is intracoronary imaging. So this is what the normal talk is, although it is still a two-way indication when it comes to because we don't at this moment in time have randomized controlled trials in terms of OCT specifically. We have for that in IVUS, but we are very close, as the experts are saying, that is quite close, that probably in the next guidelines, the paradigm shift would be from 2A to 1A or 1B indication in terms of IVUS and NP. So we must know our limitations in these cases as well. So this is a very important, interesting slide, although it's from Donald Rumsfeld, the Gulf War specialist. But I think it's very interesting to say that be precise. A lack of precision is dangerous when the margin of error is quite small. Thank you very much.
Well said, Hamid, and excellent review. So of all the data behind this technology. Dr. Faheem Jaffrey is online, and he was kind enough from Singapore to join us. He's on call, so he won't hopefully get the page during these 5-10 minutes that you have left over. So can you share your thoughts and comments about this concept of precision PCI and your role of IVUS, OCT, FFR?
Yeah, Nauman, thank you. I mean, first of all, I must say both Nauman, your talk and Dr. Hamid Sharif's talk, excellent talks, and an excellent summary of the data. I think that for trainees, I will just say a couple of things. I mean, when you talk about precision PCI, it's important to understand that the decision to treat should be based largely on physiology. How to treat precisely and effectively should then be based on imaging, whether it's IVUS or OCT. That's sort of general rule. For left main, the data is more murky because the physiology data is very limited and the imaging data is very limited. And so certainly in my practice, I tend to do both because you really need both pieces of information to make that decision. And then ultimately, whether you choose FFR or IFR, it really comes down to a choice. And in our practice, we have moved a lot towards IFR because you can do it without adenosine. You can do a very nice IFR pullback with sync vision. And you can also piggyback that with IVUS pullback on sync vision, and you can co-register and see it. So those are the sort of general principles. And I think this one thing for fellows, which I just want to make sure that everyone understands, is that stent, apposition is easy. You can have a vessel that's this big and a stent that's opposed to the plaque, but it's only this big. So apposition is one aspect of good stent expansion, stent deployment. The other very important aspect is expansion. And so you've got to make sure that the stent is not only opposed, but also expanded. And the ultimate trial, I think, is a game changer for most of us, because if you have good stent expansion, more than 5.5 or so, with very little plaque burden at the edge and no dissection, your event rate is 1.6%, which is incredibly low. And so you can't get any better. And so that sort of ties in with this concept of precision PCI, where you use these tools to actually get the best results. And I know there are issues with affordability and one has to improvise in all those settings, whether or not IVUS is feasible. But those are the guiding principles.
After the defined flare and sweetheart trial, the IFR, I think, is well validated. The guidelines have also endorsed it. Are you actually with IFR also doing hyperemic measurements and doing FFR as well? I mean, I use adenosine with IFR still, and I have a very rare occasion that it does not correlate. Most of the times, they do correlate as shown in the trials as well. So what are your thoughts on that?
So we have sort of moved more towards doing IFR only. Out of a force of habit, we will sometimes do both. I think the data will say that when there is concordance, it is very helpful and useful. And so if I get a borderline IFR, I will do an FFR just sort of to get concordance that both are negative. But in general, we've moved more towards just doing IFR for most cases.
And we didn't talk about QFR over here because not in those guidelines anywhere. But I know when one of our meetings, you showed on the case that you use QFR after angio. Do you trust any data of the QFR? Because we have, they're bringing this technology over here. The vendors have been going around and asking a lot of institutions. I have not bought in the system as yet, but what are your thoughts about using QFR?
So QFR is following the same evolution that IFR followed. So when IFR first came out, it was sort of quote unquote interesting. And we always looked to see if it agreed with FFR, and it often didn't, as you rightly said. And so it was interesting until we had the outcomes data. Defined flare and IFR suite are the largest physiology studies, and the outcomes data is very robust. And so therefore, IFR doesn't have to agree with FFR because it correlates well with outcomes. Now, QFR again followed the same trend, where it was interesting, and we have Ffr 2, which suggested that if you use a QFR-based strategy versus angio-guided, it is pretty good. And now we have the Ffr 3 study, which at 1 year has shown better outcomes with a QFR-guided strategy compared to angio. Now, we don't have a comparison of QFR versus IFR in terms of outcomes. I doubt there will ever be such a study. But based on Ffr 3, at least the data suggests that QFR now is a very good alternative to FFR compared to just using angio-guided alone. So if FFR is difficult to manage or afford or to execute in an institution, I think QFR is a very good outcome. There are some nuances as to how you take the images. You have to take good images, couple of orthogonal views, good classification. But in our lab, we've been doing a lot of QFR, and we found it actually to be pretty good in terms of.
That's nice to know, because I've had reservations. Although the data supported with the computation hemodynamics, the imaging is the key. Before that, with the CT, it didn't come out to be as reliable. That black box that they had where all the data was sent, and it's just
So again with FFRCT, the outcomes data are pretty good too. So I think you have to look at two different things. Does it match up with FFR always? The answer is no. Neither does IFR. Does it predict outcomes? Actually predicts outcomes fairly well. I would still say the gold standard is still going to be a wire-based strategy. So if you have access to an IFR, I would use that. But it is not unreasonable to use QFR compared to just angio alone. Certainly that's and it's quite affordable for most labs.
We have Dr. Asim Javed with us as a panelist, and he's been really leading the way in teaching coronary physiology and imaging. So, Asim, your thoughts on the precision PCI and any comments?
Thank you very much, Nauman, and great talks, both of you. Hats off for covering all three topics in one talk. I just want to make a few comments regarding the technique. So I think it's very important that the way the number has been acquired for the FFR, IFR, so the technique has to be really perfect. So one thing that I would like to mention is that the role of nitrates, we must not forget. Nitrates are extremely important for FFR. And then IFR is adenosine free, but it's not nitrate free. So we must make sure that we give nitrate before both FFR and IFR measurements. Then you raised a very valid point of the waveform with the damped guide. I think if the guide is damped, we know that when you have a PD over PA, that means the PA will be reduced. So FFR will be higher. So the lesion will be underestimated. So what's really important is that when we look at the numbers, we must make sure that the way the number has been acquired is appropriate. So you need to look at the waveform. You have to make sure there's no drift. The waveforms are appropriate and it's a true gradient. And only then the number becomes reliable. Then the beauty of FFR is not just the number, but it's also the pullback facility that you have. So if you're using IV adenosine with FFR, then the pullback can differentiate between the serial stenosis, the diffuse disease, the length of stent that you need, or whether it is appropriate for stenting or for CABG because it's a diffuse long disease. Then IFR pullback has the beauty of virtual stenting as well. So you can actually virtually decide if you select a spot for spot stenting, whether that would, how much would that reduce your, how much that would improve your IFR. So it's stenting that is also available to us. So these technologies, I think, are really excellent when used appropriately. We must wait for maximal hyperemia to set in, which means the heart rate must go up. If it's not going up, if the waveforms are not differentiating, you must see that whether the adenosine is actually acting or not acting, because some people are rapid metabolizers. So if you're giving it through the elbow, which most of us do, then you must see that in routine we give 140 micrograms per kg per minute dose of adenosine, but for the elbow route, I would probably go on to 180 mics per kg. And then if it's not acting, not giving me hyperemia, probably need to go towards the femoral vein or a central route. If you don't have a central line, maybe you can go and put a diagnostic aspirin into the right atrium and then give adenosine through that route. So we must make sure that the way the number has been acquired is accurate, and then the number is reliable.
All right, thank you. And Faheem made a good comment that FFR is when to do it, and IVUS and OCT is how to do it. And very important by Asim, with all, apart from all the technical aspects, that intracoronary nitroglycerin before you do either IVUS, OCT, FFR, IFR, you want to make sure the vessel is properly vasodilated and you're getting an accurate diameter, not a vasospasm there. And so I believe General Sohail Saab was also on the panelist. If he's on board, if he can give his comments before we wind up. I think he's not locked in over here. And I guess we can get closing remarks from President Nadeem Rizvi Saab. Nadeem Bhai, are you there?
Yeah, thanks. I was just a spectator. Excellent talks, Nauman, very well organized, and I think excellent talk, Hamid and Nauman both. I just want to emphasize one thing for the juniors, that it's a paradox that what you say really makes sense, that in a poorer country, I think the need for these expensive equipment is much more than in richer countries, because eventually I think in the long term you end up saving money. So even though because you save a lot of inappropriate cases, and I think the learning curve may be there in OCT maybe, but I think IVUS and FFR everyone is doing, and I think we should be using it much more, because in the long term I think you save inappropriate. Now the data is there, and a lot of inappropriate cases and other things may be avoided. So I think that's an excellent talk, and I would like to thank Faheem for taking out time, and everyone else. And I think we should. This is an excellent session. And Nauman, are we doing it next week as well? Are we doing the cases now?
Oh, so so we divided the session. We're going to have some cases that we will discuss, and there was a clash with the date next Saturday, so I'm going to announce, but it'll be within the next 7 to 10 days, the cases session. But we'll share the date by tomorrow or day after.
Okay,
So
thank you very much.
I have a question. Can I?
Yes, Ahmed.
From the panel? Yes, sir. I have a question from the panelists. I mean, so if you look at the guidelines, so why is not IVUS at this moment in time considered class 1A indication? I mean, it's still a lot of data available, specifically in the context of ultimate and IVUS XPL trial. RCT is available, randomized over a longer period of times now, and over a subset of patients, including complex PCIs as well. Why not class 1A indication for IVUS, if not OCT?
Yeah, it should be. It should be. I mean, that's been debated in many circles why it isn't. There's no class 1 indication for IVUS, which is really strange. I think in the next iteration of the guidelines, almost certainly IVUS will become class 1. That's what is anticipated. But you're absolutely right. It should be.
All right. I think we've gone above time.
I think Dr. Sohail is on, by the way.
He's on. Okay. Dr. Sohail, can you actually make comments? Are you Dr. Sohail? Can you hear us? I think he may have had the same list that you were having, joining as a panelist. So he's joined in as Vikas. Can you quickly activate Dr.
Okay.
Sohail?
Hi, Assalamu alaikum. I
Walaikum
think,
assalam.
I probably had a different link as a viewer, not as a panelist.
No, we were also having problems joining as panelists.
I think, first of all, it's a great session. I mean, I love the lectures, and the material was wonderful. The way it is presented by you and Hamid was excellent. I think for future sessions, I'm sure you're going to do it. Maybe a few MCQs for the FCPS interventional cardiology fellows later would be handy. I think there's no doubt that the data is so robust that there's no questioning the usage of IVUS and Ffr is very significant. But there's certain things which I think we always question about the cost implication and all. When we talk about local, guidelines, there's no such thing. Of course, the local guidelines are determined by the fund provider, but it's like driving a car. You drive according to laws with all the regulations, you're going to get a better outcome. And of course, you have an extremely good driver. He can drive the way he wants to and yet get away with it. But I think the way cardiology is practiced, we need to follow these guidelines. For me, one of the important lessons of all this is that even if you don't have an IVUS or an Ffr in your hospital, and you must experience it to the fullest. And so you must take home the messages which IVUS tells you, and some of them which IVUS tells you at least is they try and work out the morphology of the lesion before you stent it, and most importantly, the end result, how well should you approximate it. So, the need of a non-compliant inflation-appropriate size balloon and a significant duration, that's about 20 seconds. I mean, I've used IVUS a few times, and we found that if you don't inflate it long enough, we had a 3.5 lesion, put in a 3.5 stent. We inflated for about 5-6 seconds and brought down, and the diameter was 3. And of course, then everybody said, okay, let's take a larger size. But we took the same balloon back, we took it, kept it up for 20 seconds, and the inflation was just appropriate. It expanded 3.5. So it's very important that the lessons of IVUS and FR have to be kept in mind, even if you don't have the device in your hand. That is a proper post-dilatation. And of course, the choice or selection of lesion is very important. And when you don't have an IVUS or an FFR, it becomes a bit tricky. But the another thing which we do not probably take into account when you talk of, if you look at all the surgery versus the PCI trials, right from the Barry trial until today, the outcome is still there, that the surgery long-term outcome is better. And there's equal probably mortality, but and non-fatal MIs, but there's more to ISR. And this data that you have low centile, you get a probably comparable outcome to better outcome than surgery. So when you counsel patients, one has to be very biased. If you see the counseling which goes around to patients, a lot of patients come back to you and they're more confused about what to do, because the surgeon is going to bad lip the cardiologist and a PCI, and we cardiologists tend to tell them what traumatic and bad outcome surgery has. So it's very interesting that we must think in the interest of the patient and make a decision, guide him accordingly. For example, it's a very high centile lesion. One must convince the patient to go and have surgery. And if he thinks the surgical outcome is bad, then you must find out a place where you can get a better surgery. The other thing which I think one needs to probably talk about is the role of IVUS in CTOs and total occlusions, where it does help us a lot. I think the society, alhamdulillah, has gone big now, and this series of sessions is extremely useful. Maybe the society should own a few systems, and we should take our systems to different centers and organize small workshops in those areas where these things are not available, so that at least the cardiologists there get used to the IVUS and FR, because lots of the cardiologists who got trained in this country didn't get to be exposed to IVUS and FR. So if we have a few systems and we can take it to different centers and make the people experience it, they will learn from the experience of this and use the balloons and devices and decision making more appropriately. So once again, congratulations.
Great idea, and we should bring it up in coming society meetings. But meanwhile, a lot of the big centers have these systems and still being underutilized. So we are way above time, and really thoughtful comments. General Sahab, thank you very much. And somebody you talked about the cost thing. Somebody made a remark that during a precision PCI session, that tailored suits are expensive. So if you want to get the job done right and properly, it is expensive. And if you were to do a precision PCI trial and also complete revascularization, as a lot of Nadeem is promoting, then maybe the outcomes trial between CABG and PCI might be different. We don't know. So on that note, we'll end. And thank you everyone for joining us. Really enjoyed the session. So take care.
Thank you.
Thank you. Great session. Have a nice day.
Take care.